So good morning, good afternoon. To begin, I'd like to acknowledge that here at where I'm at the University of British Columbia in Vancouver, located in what settlers refer to as Vancouver, British Columbia, we are gathered today on the traditional, ancestral, and unceded territory of the Musqueam people. I'm really honored to live, work, and learn on these lands. In addition, as this is a virtual seminar with our friends in Toronto and across the country, we have people joining from many locations across the country from coast to coast to coast. And I acknowledge the ancestral and unceded territories of all the Inuit, Métis, and First Nations people that call this land their home. So good afternoon, good morning, and welcome to this exciting very first joint seminar hosted by the UBC Edwin S.H. Leong Centre for Healthy Aging and the Edwin S.H. Leong Centre for Healthy Children at the University of Toronto and the Hospital for Sick Children. I'm Mike Cobour, the director of the Edwin S.H. Leong Centre for Healthy Aging, and it's really a pleasure to open today's session. And we're really delighted to bring together two existing series, so the Healthy Aging Research Seminar Series and the Leong Centre Rounds, each dedicated to advancing critical areas of health research and policy for today's talk. I think the joining of our two seminars series allows us to bring together expert in child health, equity, and healthy aging, creating a unique opportunity to bridge generational health perspectives, fostering holistic approaches to well-being across the lifespan, very much in line with the vision that Dr. Leong, I think, laid out for the two centers. So I encouraged everyone to, as much as possible, actively participate in the discussion, ask questions, seek out potential collaborations. Joint seminar is not just about sharing knowledge, but also building connections that can lead to impactful change. And today, we're really pleased to welcome Dr. Kate Mulligan, Assistant Professor in Social and Behavioural Health Sciences from the University of Toronto, as the very first speaker for our joint seminar. So making history, Kate. Dr. Mulligan is currently an assistant professor in social and behavioral health services at the University of Toronto's Dalla Lana School of Public Health, and also the senior director of the Canadian Institute for Social Prescribing. She completed her MA in Adult Education and Community Development at the University of Toronto, and then moved a little further to do her PhD in Health Geography at McMaster University. And as you'll hear, Dr. Mulligan's works focuses on supporting, measuring, and scaling up the role of the community sector in systems health and well-being. Importantly, Dr. Mulligan is a globally recognized expert in community approaches to health and well-being, and she did lead one of Canada's first social prescribing pilot projects. And so really excited about today's talk and learning what Dr. Mulligan has to share with us. So welcome, please join me in welcome Dr. Mulligan for her talk on health in relationships, social prescribing across the life course. Couldn't ask for a better first speaker for a joint seminar.
Thank you very much, Michael, and thank you everybody for being here. It means a lot to me to see you and to share the space with you this afternoon or this morning, depending on where you're coming from, or the middle of the night for some people who I know are interested from the Western Pacific region, where social prescribing is really taking off, particularly for older adults. I'm going to share my screen now. And you can see that. Yeah, great. Okay. So I'm going to talk about health in relationships and social prescribing across the life course as really a way to build relationships. And so it's quite fitting to be the first in this series building relationships between the two Leong centers and in different parts of Canada. I'm coming to you from Toronto, which is Dish with One Spoon Wampum Belt territory, where we all share responsibility for taking care of one another and taking care of the resources, taking care of the planet Earth all around the Great Lakes region. I'm going to dedicate my talk today to this kid. This is my daughter, Orla. She's 9 years old, And on April 1st of this year, she had to have emergency brain surgery for a sudden brain infection. And after another brain surgery, both at sick kids, she has moved on to Holland Bloorview, which is the children's rehab hospital. And so I'm just showing a few pictures of some of the social prescribing or non-medical activities that have supported her along the journey since that time. So you can see a picture of her playing music with some therapeutic clowns, spending time outside, and doing some art, actually at the Art Gallery of Ontario. So dedicating this to Orla. She's doing really well. She was going to be discharged home this week. She got a long journey ahead, but has been really well supported by social prescribing. I should add one thing, and that is that the social prescribing type activities at Holland Bloorview are actually included in the electronic medical record, which is a really important component of what we're trying to do, which is to really recognize that these types of activities are not just ancillary to health, but central to health and health promotion. So today I'm going to talk a little bit about what social prescribing looks like across Canada and a teensy bit around the world, in policy, in practice, and in research. I'm going to talk and share some Canadian examples of social prescribing for children and for older adults, and a little bit for those of us in between. And help you, I hope, to really think about what's the role of health promotion and community partnerships and work on social referrals, how that might play a role in your own work with children or older adults or others all across the life course. So I'm going to start just by backing up a little bit. So for those of you who are thinking about concretely getting down to business, how am I going to do social prescribing? Just hang tight for the first few slides, because for me, as a health geographer and as a political ecologist of health, coming to a definition of health that is meaningful is a really important starting point for talking about community leadership in health and about social prescribing. So for me and in my work, I think of health as a relationship, a series or a network of relationships between people and their ecology or their environment. And that can be in a very literal way through things like respiration or eating or elimination, right? Or through contact with pathogens and so on. It's a relationship with between people and their history, right? The inheritances of our genes, but also the inheritances of inequitable policies or systems and practices that were designed to serve a certain purpose that don't serve us well anymore. It's a relationship between people and themselves and ideas about what we're capable of, who we are, why we might be engaging with health or social services. Of course, it's a relationship with people and other people. And this is something that actually used to be a bit of a tough sell in the pre-COVID era. But after everyone experienced for themselves what it felt like to be socially isolated, that one became a lot easier to talk about. And so now we see things like a World Health Organization Commission on social connectedness, social isolation, recognizing that human relationships are really fundamental to health and well-being. Health is a relationship between people and their access to power and resources. Again, this is intertwined with many of the others, but this is where our health equity work really comes into play, thinking about who has access not only to clinical healthcare services, but to those foundational social and structural determinants of health, and why there are inequities and what we can do to start measuring, addressing them, and changing them. Health is a relationship between people and the systems and structures around us, right? And I think this is, again, something that we can address through sometimes very simple approaches that center relationships and therefore can have an impact on the systems and structures to make sure that they are serving us in ways that are appropriate and healthy for us now. One of the challenges, though, is that our conception of health and health systems is still really static. So these are the World Health Organization's 6 building blocks for what makes a health system. They will be familiar to many of you. Things like service delivery, health workforce, financing, information, and so on. Of course, these are important components of health systems, but health systems aren't buildings. They're not made of static blocks, and there's a lot missing for what really creates health from this list. So what we end up with is funding that is also pretty static and rooted in historical ideas of what health is and where health work happens. So this is a picture of health funding in the province of Ontario, where I live, from a couple of years ago. Don't worry about every single piece of the sort of spaghetti shown here. What's important is that we notice that the bulk of funding goes toward hospitals, physician services, and prescription drugs. Right? Hospitals and physician services being what we thought health work was at the time of Confederation. And prescription drugs being what we thought health was at the time of Medicare. Okay, so 1867 and 1967, those were the major sort of revolutions in the health system that we have. Maybe we'll have another revolution in 2067 toward community, where we can start tying together some of those very tiny streams of funding that really serve communities and community health and well-being. So this is happening even though we know that relationships really underpin that system of health that we have now. We know that system is under strain. We know that people are feeling that strain, but there's a lot of work that goes unrecognized or under-recognized, often because it is racialized, feminized, or otherwise devalued. So for example, if all caregivers, unpaid caregivers, took a week off, we'd experience the collapse of our care systems before noon on the first day. That's from the Canadian Centre for Caregiving Excellence. So that's just one example of health work that happens that's not considered part of our systems. And of course, we are all well familiar with this now, that a lot of our health is determined outside of medical systems and out in our communities. So clinical healthcare is still really important at 20%, but there's lots of other stuff that's underpinning our health and well-being, things like our education and employment status, our income, but also the determinants of those factors, why we have differences in education and income and so on. So here's a picture from one of my favorite papers. It's called Beyond the Building Blocks. It's by Emma Sachs and colleagues in BMJ Global Health. And it shows in the sort of orange color those traditional building blocks for health systems. And in the blue color, those non-traditional ones that are actually there but under-recognized. Things like household production of health or caregiver work, the social determinants of health, the work of community organizations and societal partnerships, and the work of health workers, paid and unpaid, in the health workforce and service delivery spaces. What if we changed this? What if we really recognized and funded and resourced and measured this work under information learning and accountability there in a way that better represented how our health really happens and the relationships that connect these? So those little dotted lines in between the blue sections and the orange sections, that's where social prescribing happens. That's why social prescribing happens. So it's not an end unto itself. It is a tool for getting us toward better recognizing and supporting the work of community leadership in health and the work that happens in relationships. So social prescribing can really support those relationships for people right across the life course. Our relationships with place and nature, our relationships with history, our relationships with ourselves, other people, health equity and power, systems and structures, and so on. Okay, now I'm going to show a brief video that really describes the basic nuts and bolts of how social prescribing works. This was produced by Healthy Aging Alberta, which is engaged in social prescribing across that province for older adults.
Social prescribing is a holistic approach to health that bridges the gap between medical and community social care services. Did you know that over 80% of a person's health depends on social determinants like adequate food, housing, income, and relationships with others? Through social prescribing, healthcare professionals can refer patients to community-based programs to improve their overall health and enhance their quality of life. Meet George. He has diabetes and has been visiting his doctor more regularly with anxiety concerns. George thinks his anxiety is related to his diabetes. But his doctor recognizes instability in George's personal life, which could be the main cause of his anxiety. The doctor discussed this with George, and then made a social prescription to refer him to a link worker. A link worker is a non-clinical professional. This individual is employed by a community-based organization that focuses on serving seniors. Link workers build relationships with older adults and monitor their progress. The link worker assigned to George helped him to develop key health and social goals. They discovered that housing and food instability were causing George's anxiety and worsening his diabetes. Together, they determined which community programs and resources would best meet his needs. Together, they created a care plan and worked at a comfortable pace for George. The link worker also checked in on him regularly and sent progress updates to his family doctor. With assistance from the link worker, George accessed a housing subsidy and was referred to the food bank. He also received transportation support in his community so he can participate in social and recreational programs. There are many benefits of social prescribing: improved physical and mental health, increased confidence to live at home, reduced isolation and loneliness, reduced length and frequency of hospital stays, and increased community connections and natural support networks.
Okay, so that is the overview of what social prescribing looks like, at least in the Alberta context. Just trying to make it to my next slide. Whoops, sorry. Let me try this again. It wants me to explore YouTube, and that's not why we're here. Okay. So this is what social prescribing looks like as illustrated in that video. At the individual level, it starts with a person or a client who has not only health and social needs, but also gifts and interests and capacities to contribute. Often they are first in contact with a prescriber or a healthcare provider. They may identify that there's something non-medical going on. They don't need to be an expert in how to address that. They don't even need to be an expert in what it is. They just need to have enough support and capacity to recognize that there are social issues that might benefit from a deeper conversation. Then, ideally, there is a navigator or connector or link worker who's a person from the community, a community health worker, who connects that individual to appropriate resources. So they have conversations, they listen, and they change the conversation from what's the matter with you to what matters to you. And that paradigmatic shift often makes all the difference. And at times we see that the first meeting or two with a link worker are full of tears because the person's never been asked that before, and may need support to identify what matters and how they might want to start taking action on it. Then there's a social prescription where the person is supported to connect with in social and community supports as well as they can and in a way that they want to do. And I think very importantly, at least for me as a researcher, we have data tracking. So we track what happens. We put it into the electronic medical record where possible. We get that feedback back to prescribers and researchers and others. So we do start to learn more in a much more fine-grained or precision health way, how these social supports and resources are impacting people's health and well-being. So I'm going to start by with concrete examples in Canada by talking about older adults. And one of the reasons for this is that people often, when they think of social prescribing, an older adult is the first person who comes to mind. It's easy to understand and recognize that an older adult aging at home, for example, might need social supports, might experience loneliness. And there's a sector, community-based senior serving sector, that's ready to take action on this and already taking action in many cases. So this can look like support for aging in place in the community, in long-term care, in social housing, in hospital to home transitions, in rehabilitation or in hospital. or in naturally occurring retirement communities. In other words, there's sort of no wrong door to social prescribing, no wrong setting. Any kind of setting for older adults can be the right place. And I will give a shout out to those of you who are at the Leong Centre in BC, because BC is really leading the way in terms of government funding and provincial leadership on social prescribing for older adults. They recently announced millions of dollars to help seniors stay at home, including an increase in those community connector or link worker positions to 90 from 19 that they currently have over 2 years. And so their job is to develop health and wellness plans and to connect them to community programs. So great work, BC. We want to see this growth happen all across the country. So there's that link worker community connector role. Again, it's someone who can really listen, who has community expertise, community relationships, community trust, and can support the person to make connections. That might even include going alongside with them. So if the referral was to a gardening group, maybe the link worker will accompany the person the first 1 or 2 times until they know the way, they have a friend or a connection, and so on. I think it's important to note that this is not a registered health profession. And I think I would resist over professionalizing this role, because we want to value what exists in community expertise and not create too many barriers to that community expertise being recognized and supported and paid in the health and social systems. Okay, here is a video from United Way, British Columbia, about those link workers and the social prescribing work that happens for older adults in BC.
Social prescribing is a program, it's a form of prescription, and it's an approach we're taking at United Way, BC. It's an approach that is modeled after the prescription of the kind we all know that we get from GP. Typically it's for drugs or pharmaceuticals, but in the case of a social prescription, it's for some social activity.
About 1.5 years ago, I started noticing my right hip bothering me. So now I've come to the point where I'm on a list to have my hip replaced. I was pretty well isolating. I was, seeing how I would feel at the beginning of the day and decide if I should go out and get some groceries this day or whatever, and basically going back and staying around home.
Ellen's story is similar to all of the other referrals that we've got. She came to us through her registered nurse, who said she needed to be physically active. But when I met Ellen, it was clear that she was in too much pain to be physically active. And we talked about her previous life before the pain, that she was hiking and cycling and doing a lot of wonderful stuff, but no, just simply is not able to do that. So I knew the pain program was going to be here, so I recommended that she come to it.
There's about 15 or 20 of us who usually show up, and it's a very good program. I'm quite enjoying it. And being the first time that I've come to a community center to do anything, it's been very interesting for me to have contact with other seniors. So it is beneficial to come to a program like this and get to see that there are other people out here that are experiencing the same thing, and they give you a plan and things to do to help with those situations. So it's very, very beneficial.
Social prescribing plays directly into United Way BC Healthy Aging's vision for seniors in British Columbia. The vision is one of healthy and thriving older adults who are aging in place in community. They have purpose in life, they are socially connected and engaged, and that may play out in all kinds of domains of life.
I think it's absolutely amazing that these kind of programs, particularly this one, exists. It's like being a part of a community, and you could call this home in a way. You're home away from home. So that makes it very, very special. I'd like to thank United Way for supplying the support that is offered here through the social prescribing program, and for all the other places and things that they support throughout BC. It's wonderful. Thank you so much, United Way.
So I'm just gonna figure out my screen again, and we can see that how meaningful social prescribing is for participants, whether staff or community members, that it feels like home, and that it addresses things that are much more than just the initial reason for referral, such as chronic pain. Just gonna get back to where I was here in the presentation. Okay, so I did want to give a shout out to one of the affiliates of the Leong Centre at UBC, Edwin S.H, who has led a really good systematic review of social prescribing for older adults. You can check it out here. I will be sharing the slides with the teams so that you can, you don't have to write any of this down. So that's one of the most recent explorations of the evidence base around social prescribing for older adults. I think it's important to note that social prescribing is such a new intervention that sometimes it's hard to identify good research and evidence, which is why we need lots more people involved in doing this. It also means we have to look at social prescribing that might be called other things, right? That might be operating under different names. Another fantastic resource was produced by Vivian Welch and the Campbell collaboration alongside us at the Canadian Institute for Social Prescribing. This is an interactive evidence and gap map around the effects of social prescribing for older adults. So if you go to the link at the bottom, socialprescribing.ca/resources, you'll see this in the list of resources. And it's fantastic because you can get a sense of where we have a lot of high quality evidence and where we don't, where we need to do lots more research and lots more learning about what's going on and what social prescribing looks like and how it works, for whom, under what circumstances, for what types of health conditions or what types of interventions. It's a great resource. Now I'm going to move on to talking about social prescribing for children and youth, like my daughter Orla and her sisters. And this is really getting us to the opposite end of the age spectrum, clearly. And it's a way to ideally prevent some of those health conditions that might send people into health systems later in life, or might contribute to things like social isolation in later in life. So we're looking at an upstream form of prevention. We're looking at ways to address or mitigate or even prevent adverse childhood experiences, which we know increasingly have significant impacts on people's long-term health and well-being and their use of health and social services. And it can do some important work in the field of mental health promotion at a time in which we're seeing increasing numbers of young people experiencing mental distress and challenges with their mental health and well-being. So I'm going to talk about an example in Ottawa, Ontario, that is called the Vanier Social Pediatric Hub. Here at the Hub and across all social prescribing initiatives, it's really important to take a health promotion approach. And that means a process of empowerment that helps people to take more control over their health and the conditions for their health. It's a process of co-creation in which the participants and their supporters work together as equals. And that means not just for participants and their link worker or community connector, but also community members co-designing what the programs look like in their communities, co-designing what policy and funding and resourcing and support for those look like at those broader policy and system scales as well. And it's really rooted in self-determination for individuals and for communities. So at that sort of psychological scale, as well as at the political scale. That means really rooting the work in 4 key principles. autonomy or the ability of people to make decisions for themselves, competence or sort of being reminded of what we can do and focusing on our strengths or what's strong over what's wrong, relatedness, that sense of belonging that comes from having relationships, but also feeling that you matter, feeling prioritized, feeling that someone believes in you and that you can believe in yourself. And then lastly, beneficence or the ability to give back. And we see huge improvements in health and well-being for those people who are able to take a position of leadership or volunteering. And it can be something as small as a smile and a word of welcome to somebody, or something more significant like co-leading or leading health promotion activities. And this is another example from Holland Bloor Review. Imagining a world where baking cookies is therapy, where Bollywood dancing is part of rehab, and where laughter fills the halls. This is the kind of thing that we're talking about, really centering, not just at the far end of the sort of acuity spectrum after something has gone wrong, but in that preventive way upstream and in the community. So I've got, this is the last video that I'm going to show for the presentation today. This video is from the Vanier Social Pediatric Hub in Ottawa, Ontario.
La prescription sociale est un moyen permettant aux professionnels de la santé de mettre l'emphase sur l'aspect non médical de l'enfant, mais qui contribue à sa santé globale.
Can be anything from food and housing to social connection, physical activity, or time in nature.
Social prescribing allows children to get connected into their community by really focusing on what matters to them. And that's not something that is typically asked of them. What are their dreams? What are their wishes? What are their goals? And also, what are their strengths? And how can we build on those and really connect them into their community to really put them on a path to good health and well-being.
Ils ont participé à beaucoup d'activités. Elle a participé au candidat, parce qu'elle a aimé beaucoup. Et il y a beaucoup d'activités qui sont ajoutées à sa personnalité, à ses expériences. C'était un grand progrès. Je peux voir qu'il y a beaucoup de différences par rapport à Selma et par rapport à son frère aussi, Mahdi.
Je suis montée dans une vraie voiture de police et ils m'ont expliqué beaucoup de choses que les policiers faisaient et j'ai vraiment aimé en tout cas.
We have a new science of child development, and we know that adverse childhood experiences can impact the growing brain, its anatomy, its function, the stress system, and also the genes, which can then impact mental and physical health in adolescence, adulthood, and in fact the next generation. Social prescribing provides positive childhood experiences for children so that they can blossom and reach their full potential.
Grâce à l'outil principal qui est les 3 petites maisons, l'enfant va parler de ses inquiétudes, des belles choses qui se passent dans sa vie et de ses rêves. Et ensemble, nous allons co-créer la prescription sociale.
Dancing is like so therapeutic. It makes everyone feel better. But also it creates a little community of people that are coming to dance together.
What I really love about this program is because it breaks that limiting beliefs about dance. If it breaks that barrier, she could apply it to other areas of things that she may not be sure about herself.
En étant quelqu'un ayant un handicap moi-même, la danse était très thérapeutique pour moi. Et je crois que ça va avoir le même effet pour ces jeunes qui ont tant de rêves et d'ambition.
C'est vraiment bien. C'est vraiment quelque chose qui les aide à bouger.
Quand nature, le premier jour, c'était un petit peu dur. Mais le deuxième jour, c'était bien. C'était le jour où on allait découvrir des fossiles. J'ai bien aimé les fossiles.
I enjoyed going on the swing. I also enjoyed drawing and painting.
We went to go and see some exploring. We were like little scientists.
The experience at the medical school was everything that I wanted it to be. I wanted to enroll because I really like the medical field.
Je pense que je serais un bon docteur finalement. Le docteur qui nous enseignait m'a dit que j'étais vraiment bon.
I learned a lot of new things and made a lot of friends.
So I'm just stopping my screen share one last time so I can get back to the right part of this presentation. I had a chance to visit the Vanier Hub and meet some of those kids who are in the video, and it was fantastic, and they were adorable, and some of the things that they were interested in, some of the needs and aspirations that they had were remarkably simple. So Vanier is a part of Ottawa that faces material deprivation, but is also deprived of things like nature and trees and other kinds of resources. So several of the kids talked about what they wanted most being a walk in nature, some time in the park. So that's one of the reasons that they set up that summer camp program for kids. So these are a couple of quotes from participants, from workers in the Vanier Hub program, noting that social prescribing connected children and their families back to their communities, bringing back a sense of belonging, bringing back joy and hope into their lives. And they also said it had a positive impact on themselves as a health care and social care team. At a systems level, we're also seeing professionals, staff who are social prescribing at less risk for burnout and much happier and joyful in the work they're doing. And I think that is something that is quite worth noting and worth investigating further, as we know that people are facing real challenges working in these systems right now. I wanted to mention also that we have a Canadian Social Prescribing Student Collective. So for those of you who are students or work with students, we have chapters at universities and colleges all across the country involved in supporting students who are interested in social prescribing, ensuring that social prescribing happens on campuses, and connecting people into what's happening in social prescribing across a range of health professions and disciplines, so that we have this next generation well supported to continue the work of social prescribing in their own lives and in their work. And I'll mention too that we actually are starting a new initiative here at the University of Toronto. We just received some funding from SHRC to do social prescribing for students on campus and to try out to find out how it works, how it will work for our university. And again, I'm going to share some of the evidence. You don't need to write this down. I will be sharing the slides, but we've got some scoping review work. We actually have the full scoping review under peer review right now, so it should be out really soon. And working also with a really good group out of University College London with Daniel Hayes leading the way on social prescribing. So have a look at Dan and his work as well. Okay, so now just briefly, I'm going to mention what social prescribing could look like for those of us at other points across the life course. So we have across Canada population-specific social prescribing currently underway. So we have a newly funded initiative to improve caregiver well-being through social prescribing in 4 provinces across the country. We have a Black-focused social prescribing project happening in community health centres across Ontario. We have, in other parts of the country, there's a newly funded project about supporting migrant access to healthcare. This image is actually from London in the UK, but we have a new initiative for migrant workers starting up here in Ontario as well. And I would be remiss if I didn't note that Indigenous primary health care, Indigenous population and public health, and Indigenous social services have, of course, used culture as medicine for a really long time, and since time immemorial, really, and have had this relationships-focused approach to health all along the way. So this is something that a number of different Indigenous-led health organizations and researchers and practitioners and communities are exploring now to further link with social prescribing to integrate this work. Of course, we also have intervention-specific social prescribing. So things like Orchidstra, connecting people to music. We've got connecting people to nature through things like the Parks RX initiatives. We've got connecting people to sport and culture, and connecting people to food on prescription, which is happening in a number of settings across the country. And so I've listed a bunch of the evidence here around those. Again, we have more evidence for the different types of prescriptions or the types of interventions than we have for the types of populations. And one reason for that is that health equity was not at the forefront of social prescribing in the UK, where this really got started. And it's through a lot of Canadian leadership, in fact, that health equity and a more diversified approach to social prescribing and its measurement, evaluation, and implementation has really focused on those populations. So we should see some increases in research around different populations in the literature over the next little while. Across the country, there are a number of promising health system trends that show places where social prescribing might fit well. First, I want to note that we worked with KPMG management consultants to do a social return on investment analysis about social prescribing, finding that $1 invested into social prescribing can have an average return of $4.43 in terms of improved well-being and reduced costs to health systems and governments. And we know that social prescribing can fit into some of these other health systems and trends across the country. The growth of team-based approaches to primary care, expanding scopes of practice for allied health, so pharmacists, social workers, and nurses, for example. And I'm involved in a project for pharmacists right now to get involved with social prescribing. There's an increase focused on system navigation and care coordination, which is one component of social prescribing. And there's an increased focus on strategies for social and structural determinants of health and health equity across health systems. And we do see social prescribing initiatives happening in every province, not yet in every territory, but in every province across the country. You can have a look at some of them on an interactive map that we have on our website at socialprescribing.ca. And if you don't see yours represented there, please add it in. This is a map that is crowdsourced, so please do add yours to the growing list of initiatives happening right across the country. On the website, we also have other webinars you can check out to hear more about the evidence that is sort of in pre-publication, that map of evidence about social prescribing, a policy scan, a deep dive into understanding the social needs and perspective of older adults, and some investigation of what makes a co-design process successful. So I talked about co-design and collaboration. That's the process we've tried to take at that pan-Canadian level to have different organizations and different people working together, including people with lived and living experience of health inequity or of social prescribing itself, coming together to co-design what we think this could and should look like across the country. We are part of a global movement on social prescribing, and this is a list of the growing international social prescribing collaborative. And at that international level, I've pointed you to a few resources here, global developments in social prescribing in BMJ Global Health, and a couple of new books. So this blue one, Social Prescribing Policy, Research and Practice, is an academic text. I have a chapter in there on social prescribing in Canada, and there are a number of chapters from all around the world on what's happening in social prescribing and a few different approaches to what it currently looks like and where it could go from here. And then a brand new popular focused book for everybody called The Connection Cure, which investigates social prescribing around the world and does include several of our examples of folks here in Canada doing this work. It's actually just officially released today by Julia Hotz, who's an American journalist. When thinking about measurement, I'm not going to get into this in great detail, but I'd be really happy to have follow-up conversations with anyone who's interested. When we're measuring what matters in social prescribing, we want to look at not just individual health benefits, although that's important. We also want to look at whether we're making our public systems better. So are we addressing that quintuple aim that does things like reduce costs, improve health and well-being, improve the care team's well-being, improve equity, and so on? Are we using a learning health policy systems approach? In other words, are we using measurement and evaluation to help communities better understand decision makers and their needs, and to help decision makers better understand communities and their needs? Are we sharing data in a way that's as simple as possible, as shareable as possible, and as meaningful and useful as possible for people? And then the part that I think for me is really powerful and interesting, again, as a health geographer, are we shifting power and resources to that community scale and to people in community who have a lot of knowledge, a lot of experience, a lot of expertise and capacity, but need more power and resources and stronger relationships to really exercise that in a way that is beneficial for them and for everyone. So, how to get started with social prescribing. There are a number of resources out there that you can check, but I'll just mention a few key things. Start with what's strong and what you're already doing well. Map the community assets and make sure you have a good sense of what's out there already. You don't need to reinvent wheels. Focus your measurement on just the core things that matter most to people, to communities, and decision makers. And just try it out. Keep learning, keep working together. And that's how social prescribing has really grown all across the globe, primarily at local, regional, grassroots levels where people are trying it out and improving as they go. I would love to invite you to the first Canadian Social Prescribing Conference, which will be happening here in Toronto in September of 2024, Advancing Social Prescribing for Health and Wellbeing. I know a number of you will be there sharing your work, and I cannot wait to meet you and be with you in person at that time. And I'll close it off with a couple more pictures of Orla doing more social prescribing stuff, doing art, doing hockey, which has been a big motivator for her, and a little intergenerational picture in the middle, a nature walk with my mom, her grandmother. Thank you so much for having me. I look forward to being able to have a few minutes for questions, answers, conversation, and I hope sharing of the leadership that you're doing in your communities across Canada and around the world. Thank you.
Thank you very much, Kate or Dr. Mulligan. That was terrific. For those of you who don't know me, I'm Master Gutman. I'm one of the co-directors of the Edwin S.H. Leong Centre for Healthy Children. So, really delighted to hear this. So we do have time for questions. Before we do that, I will just also flag that this is the first of our joint lecture series, and we will be doing another one in the fall. So stay tuned for that, and delighted to see how many people are on the call. So I have a question. I'm happy to start with it, but I'm just trying to see if I see hands. Oh no, sort of in the chat. Sorry, this is Zoom, not Teams. Well, I guess so. Maybe I'll start with a question, and then it looks like Arjun has a question, and then Margaret Lynn had also put a question from UBC. And so, Kate, I'm wondering, and it's interesting your analogy or your example from your daughter. I know, for instance, at many pediatric hospitals, things like the art program and the child life, that ends up getting funded literally by foundation dollars. It's not like a core part of what gets funded. And so just as a microcosm of, I think what you spoke about, a lot of health ministries are not doing, they are not funding these important programs. So I just wonder about your reflection on, to a largely kind of research audience around, is this the evidence base has to get more granular about dollars saved, or what is it, or not enough of this has been trialed, and so people think the level of evidence isn't strong enough, or I don't know, just some reflections that could sort of guide people.
Good morning, Pix Office.
As they do that research.
Yeah, great question. And I mean, this is true of any health promotion and community development work that happens anywhere in our systems. It's always the first to be cut when cuts need to happen. And it's typically unstably and underfunded. This is the story of community health and social determinants work writ large. So I think there are a couple of reasons. One is that, we don't have a fine-grained or precision evidence base. Although, there's a huge evidence base for the different kinds of prescriptions that people might offer. So there's a lot of evidence about how arts and culture interaction improves health and well-being. There's a lot of evidence about physical activity, time in nature, and so on. There's less evidence about that referral process for social prescribing and that connectedness at the individual scale. So what we have are sort of ad hoc examples from around the world of different kinds of initiatives that people have done, but it's not systematized. So I think we do need to build that research evidence base. We do need to think about including these activities in the medical record, because I would say most hospitals don't. So it's never considered to be core health work. And so once we start doing that, my expectation is that we will be able to demonstrate what the impact is, or range of impacts are, on health and well-being, on the use of more expensive or acute health services. We will also be able to make the case for where more resources are needed. So, one of the fears people have about social prescribing is that we'll have what they say, like, too many travel agents and not enough holidays, or we'll be referring people, but there won't be the services there that they need. And so this is also a way for us to measure in a systematic way what the demand is, what the needs are, and report that back to those funders, so that we can talk about and think about this happening in a systematic way. So for researchers, I think that part's really clear. For those of you who are policy workers, one of the biggest challenges is that we don't have well-being budgeting across Canada. And what that means is different ministries or different departments compete with one another for resources. They don't think collectively as a whole of government in terms of that funding. So even if we demonstrate that these activities save money, we need to show that they save money to the people who are making those decisions about this particular type of funding. And so if investments in community services save the health system money, unless we think of them as part of the same system, it doesn't translate. And so it doesn't help. So those of us working in policy research and policy influence have that challenge to really address, to help us think in a different way about what money saving really looks like and means in our sort of policy contexts.
Yeah, very interesting. That's come up in many conversations about different things, the lack of joined up government and all of the limitations of funding. We have a lot of questions. I think Arjuman was first.
I'm going to keep it really brief because I want everyone to get in. So feel free not to answer, Kate, and just food for thought. I'm wondering if there is an analogous kind of healthcare system, population health perspective that you would take on the concept of social prescribing or the substance of it. Meaning, is there a social prescribing role in the healthcare system? And then also this is about things we should be doing sort of more fundamentally at the population level, and access that we should have and lives that we should live sort of more generally, for what it's worth.
Yeah. Okay. So I'll try to answer that really briefly. And I think it's a great question. And I don't think there is one clean analogy. I think there are components of different roles that are not systematized and not conceived in that way. So care coordinators, for example, it's a very similar and closely linked role, but it's not everything. It doesn't necessarily take a health promotion perspective or coordinate social services and health. It might just be within a health service. Again, health promoters, community health workers, there are some similar kinds of roles, but no, there isn't one that really centers and systematizes this in a way that's meaningful for people. I do think that those people who are doing quality improvement might actually be really vital and important for linking that population health scale that you mentioned and that individual health scale. So if we really think of this in terms of that quintuple aim, that and the impact on health systems, that is the probably where the most bang for the buck is in terms of influencing people who are within health ecosystems. For influencing funders and decision makers outside of health and community and social services or with other priorities, sometimes it's much more that individual or community change sort story, which might be more qualitative.
Thanks so much.
Catherine was next.
Thank you so much. I was going to ask about public health nursing and health promotion activities, because I think some, but not all, of what you've been speaking about used to be part of the role of public health nursing, and but that's within a healthcare designation. And my second question is, we've been collecting data from children and families around, I think, some of the data points you're talking about, like library use or early on center use. But we've had a hard time finding a framework by which to bucket these different activities. So maybe after I can speak about, if you might be able to point me to some frameworks where we can make sure we're collecting the data that would be interesting to you. Thank you.
Okay, so my own career background is in public health and in community health. And so, yeah, there has been historic disinvestment in community development and public health nursing, and sort of any community.
Good morning, Better at Home. This is Maria speaking. How can I help you?
And so that is a challenge. And I think one of the challenges I have now in speaking with my public health colleagues is that there's even a paradigm shift toward thinking that anything that isn't policy work or big P population work isn't public health at all. And I think that's a real challenge. So I did write a report 2 years ago for the Chief Public Health Officer of Canada's report on the future of public health. It's all about that community connectedness. So I can share that with folks afterward, because I really do think we need to reinvest in that and consider that community scale as fundamental to the work of public health. With respect to frameworks for data collection, I agree there really isn't a good one. And most social prescribing work has happened because local people wanted to make it happen, and we're operating on intuition as much as anything else. Yeah. So we have a lot of work to do in terms of really capturing the data in a way that's meaningful. And it's something that I have been working on over the past year. I'm a bit delayed because I've been off with Orla, my daughter, but I have been building toward this framework for understanding the impacts at those different scales. So the person, the place, the public systems, and that learning health policy system in a way that, well, I won't get into the details, but I think there is a way for us to take an indexing-based approach that helps us share across really diverse types of initiatives and indicators. So happy to have future conversations with you and anyone else who wants to talk data.
Thank you so much.
Thanks, Kate. I also just want to flag, there's some questions about like the conference, whether it's virtual, that I think what we will do is just send those to you by email and just try to connect the answers. Okay. Just because we're running out of time. Maybe the last question to Diane.
Hi, good morning. Thanks for the presentation. It was awesome. I've just recently become one of the senior community connectors. So this is really kind of cool and interesting. And I'm wondering if you can give me some perspective on, how that social prescribing is being perceived for seniors in particular. Like, I could see where it's really welcoming, to, children and youth but I'm wondering if there's a little bit of a reluctance from seniors, especially if they are isolated or maybe have limitations on such a program. And I know you gave the example of the gardening club and, maybe, the assister, actually assists or accommodates that referral, that client to that program. And I'm wondering if you have any other suggestions if there is, reluctance initially anyways, as to trying to make that program welcome.
Yeah, so good question. Yeah, I mean, often there is, and people, particularly people who feel proud of being independent, may face some challenges in reconnecting to people, or may perceive these supports as being for somebody else, not themselves.
Right.
And even in that video shown from BC, it was someone who had never used a community center before. So it definitely happens. I will point you to the work of Dr. Kiffer Card, who's out of Simon Fraser, and he's on one of those webinars that I mentioned that's on our CISP website, the Canadian Institute for Social Prescribing. He's done some really good work on those perceptions that older adults have about social prescribing. And I'll just share briefly a couple of interesting findings. One, they are more likely to trust people working in community organizations than in healthcare organizations when it comes to social referrals. Two, perfect. They're more likely to trust people in healthcare organizations than community organizations when it comes to their data, which is probably not surprising. They know that there are good, strong protections in place for health data, and that less so in the community and social services side of things. So I think it again points to the need to collaborate and work together. But if you look at Kiffer's work, you can explore kind of those perceptions. He's done work with folks from a lot of different social and sociodemographic backgrounds all across Canada.
Thanks, Kate.
Thanks very much, Kate. Scott, I'm really sorry. We are at time. You were waiting patiently, but if you would like to email the question, we can certainly, facilitate getting an answer to you. And Kate, I feel like we might end up having you back. There's so much to this. And I think it's of huge interest to both centers and our membership, which, are not just researchers, but as you've seen, people who are actually in the community doing the work. So maybe we don't want to lean on you too heavily, but there's just been, I think, just all of the discussion in the chat, and as well some of the questions that go deeper into different areas, policy methods, etc. So thank you very, very, very much. Really glad your daughter is doing better, and this was like a really terrific talk. And again, thanks to everybody, wonderful turnout, and we are looking forward to welcoming everyone back in the fall for another joint seminar.
Thanks so much.